And welcome back to WoundCasters by Wound Care Today, where we explore the gaps by exploring the truth. I'm your host, Felix Boecker, and today I'm excited to share my first ever two-guest episode with Traci Kimball, who is also known as the Wound Wizard and founder of the Wish Clinic, and Cassandre Voltaire, who is a practicing wound care clinician and also the founder of WoundFit, which is a consulting firm, but I'll let them tell you more about exactly what it is that they do in the world of wound care right now. Traci, thank you so much for being here today. Welcome to WoundCasters.
Thank you, Felix, and hello, Cassandra from Denver, Colorado. I'm Dr. Traci Kimball, a wound care surgeon, been in the space now for almost 13 years. Yes, I am founder and owner of the Wish Clinic, Whole Person Restoration Center in Alvarado, Colorado. Happy to be here today.
Yes, so happy to have you. This is so exciting to have both of you on. Cassandre, welcome to WoundCasters. How are you doing?
I'm doing super well. So yeah, I guess hi to the audience. As Felix mentioned, I'm Dr. Cassandre Voltaire, and just a quick introduction. I actually started my path in healthcare as a CNA, and the reason why I brought that up is that it's really formulated everything that the way I view wound care right now and healthcare in general, just teamwork and the human side. And I actually got introduced to wound care officially as a resident during my very first inpatient rotation. And during that time, I felt completely unprepared and I felt like I wasn't doing enough for my patients. So that really set me on the trajectory to where I am right now. So that's how I eventually created WoundFit and a consultation company to help people feel less alone than I did all those years back then. So Thank you for having me on.
No, absolutely. And I think what's so exciting is Traci comes from the background as a surgeon, but you come from the background as a primary care physician. So we have a broad spectrum of expertise here. And like you said, CNAs are so important in the medical world. And they're really under-recognized, undervalued, underappreciated, and overworked at the same time. So, having that perspective, I think, is so important. And so thank you for sharing that with us. I do want to know how the two of you met. How did you cross paths? Because I know when I reached out to Traci about being on this podcast, she had mentioned, oh, no, we got to get Cassandre on here. So what's your guys' story?
Well, I'm actually going to parlay that from what Cassandre just shared, but I think it was just a recognition. I met Cassandre virtually on LinkedIn, and of course, an algorithm, social media channel seems to put people in front of you that it thinks that you're going to align with, synchronize with. So I'm going to chalk it up to technology. But ultimately, learning Cassandre as a person and a human and a clinician, it really struck me that she has the power and the vision to really engender someone's passion in wounds, in the wound medical specialty. I come from a lineage of surgeons and surgical training, and I actually was going to be a vascular surgeon and partially trained in vascular surgery at the University of Utah, and then eventually got into wound care from there, trying to raise a family, be a mom, do all the things in my middle career and end of training life. But what it did is put me on a path of traversing the post-acute venue of care for wound medicine, and of course, being a surgeon gives me that extra edge of skill set, no pun intended, or maybe pun intended. To actually do the more interventional work. But what I did learn in my path is, and the topic of potentially this podcast was the importance of an interdisciplinary team and why it takes a village to do what we do and do it successfully, holistically, with the patient being at the center of care. And so bringing it back full circle to introductions with Cassandre, understanding that she's an osteopathic physician. Actually didn't know she was a CNA, but it makes complete sense because Cassandre can speak very eloquently and experientially and from an expeditionary learning standpoint, that she really found her niche and her passion to wound medicine, most likely from the genesis of her career as a CNA. And when we talk about adapting and the experiential nature of this specialty and the fact that it's not taxonomized, recognized by the American Board of Medical Specialties, it's really important to realize that wound medicine has its genesis in nursing and allied health professions. And so my experience coming into the space as a surgeon, being thrown into or thrust into the post-acute world at the bedside in skilled nursing facilities all those days ago, really learned who the hands are that really, create healing in this specialty. And so I learned from them, So it was the CNAs, it was the LPNs, it was the RNs and the ONs that I learned a lot of what I know, and of course brought in the surgical skill set and mindset and theories of pain management, hemostasis, infection control, source control, all these things, and of course physiology and anatomy that we'd have to know as surgeons, vascular inflow, outflow, all these things. So yeah, I think when I was on LinkedIn, it figured out, this person must be somebody Dr. Kimball knows and introduced me. And then of course I introduced myself in person at one of our national meetings.
Yes, that's fantastic. With all that, Cassandre, do you have anything else to add from your side of the story?
No. Traci explained it very thoroughly, but I just what I guess I would like to add is just going back to the interdisciplinary team-based idea and just the appreciation. I think it's one of the things that gravitated me towards Traci and just her passion for it, in addition to value-based care, and just how they're both intertwined and they're both essential to one another. And especially given the fact that she really believes that wound outcomes are team outcomes, like she just said so eloquently. For myself, the best cases that I've seen didn't heal because of one person, obviously. They healed because everybody aligned, right?
Right.
And most failures in wound care are communication failures, not just clinical failures. So once the team shares the same story, which Traci has said before, the wound it moves in the right direction for the most part. And it's not really about adding more people. It's about creating clarity, right? So the IDT already exists in one form or another in almost every position or space. But the question is, does everybody know their role? Mm-hmm. And that's when it really shines. So
yes. And that's such an important piece, I think, that everybody knows their role, because wound care is such a multidisciplinary team, right? You need not just the wound care clinicians. You don't need just the nurses. You need also the primary care physicians, the endocrinologists, the vascular surgeons, the podiatrists, the plastic surgeons. You need everyone really to look at all the little details. And it's when everybody comes together and knows their role, and we're working together towards the same goal, which is healing the patient, that the magic really happened. So tell me more about this IDT. How did it come about? What's the structure? How are you guys implementing that in your own practice?
Oh, I'll let Traci start.
Okay.
Well, Felix, as you know, as a surgeon, we're team leaders in the OR. So I think when we're I guess created, selected to be surgeons, we're being selected to become leaders of a particular, challenge and problem solve, and pulling a lot of people together, an anesthesiologist, a circulating nurse, a surge tech, and then the surgeons and then the residents and all the people that are going to help this patient, even down to the environmental services individuals that, are cleaning the OR, making sure it's sterile and aseptic for us to perform our craft and take care of the patient and do what we need to do. So I think there's a lot of that. That can go, and what drew me to surgery was, my penchant to want to always be on a team. And so that comes, that goes back to being on teams when I was a kid and playing sports and all these things. But the bottom line is that you're right. And it's all about the team outcome. And again, the patient outcome, and it takes a village, and the genesis of who is involved in the role at least for me, being a part of a program of all-inclusive care for the elderly for 7 years, I knew we had one singular goal, and that was to instill life, longevity, and wholeness to our patients because of the economic model. And so it's funny how we can relate, clinical outcomes and clinical protocols to an economic business KPI, but we were not in the business of allowing patients to lose their limb and lose their life, because a patient life was very important to an all-encompassing, all-inclusive program that was paid based on the number of patients they had in their program and how sick they were when they were enrolled. And so once they were enrolled, our goals were to bring them to health as best as we can to extend their life, and of course keep them out of high cost, high utilization centers where spending happens. And so to do that, we had to build a program and incorporate all of the elements that go into keeping patients whole and bringing and restoring longevity. And so that includes not only the technical process, or the technician, or the surgical dressing, or wound care dressings, but they are surgical dressings actually, according to the coverage determination and HCPCS code system. But it wasn't just about that. It was about managing their social determinants, managing their transportation, or their food insecurity, or even their financial insecurity, because PACE specifically covers a lot of their, most all of their medical costs, and bringing services to them. And doing that with cost floors that made sense to the organization. Some PACE programs are nonprofit. The one that I worked for was a for-profit conversion while I was there. But again, the goal was patient-centered, focused care that brought all these multidisciplinary services to the patient in the center of that care. So I was charged as the leader in the team to bring all these individuals together. And guess what? It was during COVID when this all started to really come to fruition.
Of course.
So now we had this adaptation we had to create, to manage and strategize of having to deliver all these services as virtually as possible. So I was lurched into this role as the subject matter expert for wound medicine in this organization that's nothing but primary care from the charter. For many, many years ago, when it was chartered, this program was chartered in San Francisco for a Laotian community. But that's where it came together. And of course, again, through the humors of synchronicity and pretty good operational management by the organization, we were able to pull together this interdisciplinary team that encompassed the surgeon or the physician at the center with the patient, the nurses who gathered around and either did, case management or technical aspects of dressing care, allied health professionals, so rehab specialists, providing clinical exercise programs for patients to increase their metabolic health, help them lose weight, adapt to their bodies if they had an amputation, a contralateral limb, or needed off-weighting shoes, compression garments. The allied health professionals assisted with that. Palliative care teams came to those meetings, and we brought these people together and we met on a rotating schedule. So, and that is how we managed basically 250 wounds across the state of Colorado. Well, wounds plus, wounds of patients in the state of Colorado during a closure time when we couldn't even touch the patient. Now, mind you, we did put nurses in PPE to the bedside, with the hardware to do and conduct these visits and updates with the patient and call them check-ins. But yeah, I mean, there was a consortium of individuals that were already a part of the operational infrastructure of the organization. And like you said, they already existed. Everybody just needed to know their charter and their role. And weaving together that quilt of care, is what I like to say, was going to be the challenge. So, and depending on your organization, the quilt might already exist, but there might be moth-eaten holes in it.
Right.
So it's a matter of reweaving those fibers together again and creating that holistic team to then approach and wrap around the patient. And I've said that in other podcasts that I've done on this, but it truly is wrapping this quilt around the patient to get them whole and back to health.
I like that analogy a lot. The quilt wrapping around the patient. That's really good because at the end of the day, it is about the patient that we're doing this. Yeah, Cassandre, I was wondering what your thoughts here were from everything Traci said. What does IDT look like in your world, and how have you implemented it?
Yeah, no, firstly, no, thank you, Traci, for just sharing again your experience with it. I'm assuming it was through the PACE program that you experienced all this. It's just, I just really appreciate how this style of care just assumes like the entire team is responsible for the patient's trajectory, right? It's just, and that's just how it should be. But, as a family medicine physician, I have experience with IDT in a certain way, but as far as like skilled nursing facilities, it's just mainly where I'm doing wound care at the moment. I guess one of the things that I like about where I work, SNFs, is that everybody sees something different, right? So PT, OT, they see function, right? And CNAs, they see routines, and nurses see clinical changes, right? So, and the providers see the big picture, but they're all important, when they combine. So I guess just to help with sharing this a little bit more clearly, let me share a story. There was a resident who, it's just one of several stories, they just felt sort of off, nothing dramatic, right? The wound wasn't looking really bad, but something in the healing trajectory just seemed a little off. So meanwhile, PT, they jumped in. Thankfully, they noticed that his gait was slightly lower, and as far as like his offloading, it wasn't optimal. And the CNA saw that he wasn't really finishing his meals and nutrition. They caught that it wasn't really optimal, and nursing found out that his vitals were trending a little bit off. And so individually, these were all sort of tiny things. But together, they told a story, right, of early decline and poor decreasing function, and as a result, because of all this, poor perfusion and just slower healing wound. So, because everybody shared what they saw, we were able to catch it early. We were able to do preventive measures a little bit earlier. We were able to adjust his care plan a little bit better, more proactively, and we probably avoided what could have been like a hospitalization or a serious wound complication. So this is like one of many like different stories like that. But for me, it's an example of incorporating IDT and in a way that creates a space where those small observations can land well and they can add up to something meaningful. So that's one aspect of why IDT is so important to me. So.
Yeah. Cassandre, I have a question for you. You're on here with two surgeons, and you're not a surgeon yourself. But I actually just yesterday recorded an episode for WoundCasters on surgical closure techniques, whether that's delayed primary closure, skin grafts, flaps, right? And I feel like they're underutilized in the wound care world because there are so many non-surgical providers out there, and we're so focused on the dressing choices that we sometimes fail to see the potential for a surgical closure, which can expedite closure, actually. So I'm wondering, from your perspective as a non-surgeon, how do you interface with surgeons in your IDT? How do you make those referrals? How do you make those connections? How do you build those relationships so that when you do have a patient that you think might benefit from a surgical intervention, that the patient can get the care that they require, deserve, they need? How does that work in your world?
Yeah. So from my skilled nursing facility, we tend to be, we don't have, unfortunately, it varies from facility to facility, but our lines aren't as direct as if, from compared to when I was a family medicine physician. But as in other settings, having a good foundation, a foundation communication really makes all the difference as far as like easier facilitation of communicating whether or not I might need some additional help from a surgeon. So reaching just from the get-go, just reaching out to your local community of healthcare providers. So for me, it's the VA system. So when I first started, I reached out, just said hello, just explained, fact that I'm a new provider, and just just let them know that I'm also a wound care physician and I might need their input every now and then, more specifically vascular surgery, especially given the fact that we especially have two patients currently who need some additional assistance in that matter. So just getting that early groundwork of communication has been super helpful for me in different settings. So in addition to that, just leaning into their input, because I don't know all the answers, obviously, right? Of course, I have a background in family medicine, so I know the basic pathophysiology, but there are those subtle variations, that gray nuance, where I don't hesitate to get some additional help. As we've said before, nobody's a silo. So if there's something off, if I have a patient who might need an earlier consultation, an early evaluation, if his foot is looking a little bit duskier, then, I call them. I don't hesitate to call. And luckily, I'm blessed to have at least one physician who is more than open to share the input, bounce ideas off each other, and just let me know, hey, maybe we could get him in a little bit sooner. So really just leaning into that additional knowledge makes all the difference as far as just determining whether or not, additional resources are needed.
Yeah, absolutely. Now, Traci, your perspective is going to be a little different because you come at it from a surgical background, but coming from a vascular background, you may not have the experience. I don't know, you have to tell me, but you may not have the experience with major flaps reconstruction, for example. So there may still be cases that you may want to send out to a plastic surgeon. Do you have anybody in your Rolodex, in your speed dial list? Do you have anybody on your team who can help you out with those cases?
Yeah, and before I go into fully answering the question, so yes, the answer is yes. It's a very important as a part of the reconstructive ladder. I think because I have a little bit of that transformative experience being a part of a primary care organization as a wound care subject matter SME and technical provider alongside primary care, what I really think there's a lot of gaps in not only, or maybe it's not a gap, it's an awareness piece, a sphincter tone piece between both types of providers. So when we talk about, the reconstructive ladder or even just wound medicine in general, it is a dichotomy of medical management and surgical care. And then it's okay, well then how do we again weave those two individual thinking silos together, and where do we share or find common ground? And what I believe as a transformation or a change in this environment, because there are a lot more medicine-based or, primary care or just say pure medicine-based scopes of practice doing this work. What I think and as you pointed out, Felix, that the surgical venue could be the best path or the fastest path to healing and wholeness. And so understanding when that patient is a candidate and making that decision with compassion, because that brings in the ethos of the generalist or the primary care or the medical management side, when that patient might be the best candidate. And so my theory when I was in PACE was to instill this be fast to ask philosophy.
Yeah.
Be fast to ask philosophy. So I come from a training program that was heavy on first responder care, building critical access programs for emergency care in a fairly rural state, in the state of Colorado. And I worked in the Denver health system, which developed the first emergency medical system in the country. And so we were always there when the patient arrived, regardless of their diagnosis, because if they needed hands that were surgical to help with hemostasis, help with, immediate controlling hypotension because, the patient was bleeding, we were there. So be fast to ask. Having a surgeon simply come to the bedside and say, patient is or isn't a surgical candidate makes life a lot faster and easier for everybody. Because we're just simply ruling out the possibility of fast and eloquent and durable closure
Yes.
With
Yes.
with primary closure or delayed primary closure, tertiary closure, and then the whole concept of dressing selection, wound bed management, source control or biofilm control with dressings is not so much of a thought process in the care planning.
Yeah.
Now we understand as surgeons, not every patient is a candidate because we have to not just look at the hole and think we can close it with suture or soft tissue or moving, structure into new structure and function, but we have to look at the patient's potential performance after that procedure. And so that interaction between surgeons and first responders and primary care providers was very crucial for our program because it helped them think more like a surgeon in many ways, because they are the first responders. They are the patients that are receiving, or the providers receiving the patients on intake. And so when they're like, what would Dr. Kimball do? I may not have always gotten the call, but at least I've instilled some of the philosophies and thinking of a surgeon into primary care specialty for the wound problem. And therefore, fast to ask happens almost automatically and organically, because now the primary care specialist who might have done maybe 3 hours of surgical contact time in their training, didn't really pick that up. And so it's that nuance, as Cassandra likes to say, that I feel like helps with an adaptation for primary care specialists in terms of their thinking when they approach a patient on what needs to happen. And then they're more in tune with clinical findings that are surgical, just like she pointed out. Well, I'm calling vascular because I'm looking for skin changes and I'm the dusky limb, with a big, heel ulcer in the middle. And so she's already in tune with that subspecialty, but you raised a good point. What about soft tissue reconstruction? But a lot of times we also have to think about the venues in which we operate. And I'm not just saying operate like in an operating theater. I'm talking about where we function and we're rolled and permissioned to heal our patients. She's in a skilled nursing facility. The risk inside a skilled nursing facility, meaning population dynamic and population demographic and risk, is a lot different in an ambulatory than what you see in an ambulatory setting, in a hospital outpatient department, for example, which I've worked in and I've managed. I'm also hyperbaric trained, so I've been inside of those venues. But the people that walk into a hyperbaric wound center of excellence versus somebody that's in their bed, permanently disabled and dementia ridden, and malnourished or nourished in a skilled facility, they're very different. And so their ultimate outcomes is the compassionate side, right? To say, okay, what is the patient's performance? What can they physically do to heal their wound? What is their body capable of? And that's where I think primary care or maybe medically based professionals can teach surgeons and reinforce a lot of the things we probably remember from our training, but I worked in an environment where there was a lot of interdisciplinary conversation, and we had, in the ICU, we had nutritionists rounding with us all times. And we basically said, okay, what does the nutritionist think? Are we hanging TPN? These are the things that, the medical management side of even surgical care comes in, just adapting that to wound management as well. So I think there's this collaborative conversation that needs to happen more, I think, in the various settings in which we traverse and touch, and understand that not everybody in her setting have the propensity to heal no matter what we do, surgical or non-surgical. And so having a lot of that compassionate consideration when approaching a patient is important, and vice versa. And Cassandra, from her lens, that, is it time for me to consult a surgeon? And my answer is always ask fast.
I like that. Ask fast. I'm going to have to start using that. I like that. That's really good. One of the things that both of you have mentioned is that collaborative communication. And what I'm wondering, because Cassandre, you had mentioned earlier that the number one breakdown is with communication. And we always talk about the communication breakdown between the different providers and the nursing staff and the medical professionals. But we rarely talk about the communication breakdown between us as the professionals and the patient, who's the one that we're treating, the one with the wound, the one who actually has to deal with these problems 24/7, right? So how do you incorporate the patient into this interdisciplinary team? I mean, I like I said, I like the analogy of wrapping that quilt around the patient and making the patient the center of things, but there's still communication that needs to happen with the patient for them to understand our perspectives, our recommendations, where we're coming from with what we're trying to recommend, but also balancing that with their own needs, wants, and desires out of life, which may not actually be, I want this wound to heal in the next 6 weeks. Like that's what we would want, right? But they might say, well, my granddaughter's graduation is next week and all I want to do is attend that, right? And that may be the only thing that they're concerned about, and less so the wound. So how do you balance that? How do you incorporate the patient into this IDT? What's your communication like with them?
Yeah, no, that's a great question. I think to start with answering that, I think just overall with it's human nature to want to be seen, right? So we start from there. And from there, we ask about, like you shared partly, what are the patient's values? And I think that's a good jump off point as far as how do we get the patient to buy in and to become part of the team that is involved, who's an important member of their healing process. So like you shared, like whether they value safety, whether they value comfort, we really have to take that into consideration as far as how we can adapt the wound care plan so that it optimizes patient buy-in and in turn optimizes wound healing outcomes. So I guess going back to a story, there was a resident recently who had a pretty, we're working on it, but he always slept on the same side, right? And he is his own person, and we've talked about as far as repositioning, and but it really hasn't really been sticking. But we talked to him one-on-one, and he's a veteran. And we eventually found out that, we knew that he has a history of PTSD, and his reasoning is that he prefers to face towards the door because he feels safer for different undisclosed reasons. But that really opened the door as far as how we could optimize his healing, work with him as far as optimizing offloading, even though that, just as far as shifting isn't really optimal in that setting. So really just listening to the patient. There's so many other stories in primary care as far as just listening to the story in the background as far as why the patient is at the point where they are, whether it's psychological, whether it's just their whole environment, whether they can afford to get to a clinic on time, whether they can afford certain dressings, or whether they have the time to perform certain at-home dressings on their own. So it's just really listening to the patient, getting into their story, understanding the values, making sure that they feel seen, right? And all of that together optimizes patient buy-in, helps them feel like they're a member of the team, and it just really just improves outcomes significantly from my experience.
Yeah, I agree. Traci, got anything to add from your perspective?
Well, there's a very primary lesson to be learned about everything she said, and it's really the ABCs of wound care. So appropriate assessment, having an eye and a lens, and understanding what we're looking for. And that we can look very differently, whether it's a surgeon or a primary care provider or allied health professional or a nurse, because of how we're educated, which speaks to the multi-scope, multidisciplinary, multi-specialty nature of this field, which also speaks to why we need to truly codify our specialty and bring us all together and really find the similarities and create, training programs for every scope that touches this. that are linear, not experiential and divert, and just add some consistency, I guess, into the training. So it can be validated, accredited, and certified, and we can develop curriculums around it and then testing around it to determine that you do meet the criteria of a wound care specialist. But then understanding dressing selection and bandages. So that's the B. Circulation is extremely important. It's critically important because, like I say, if you don't have oxygen, no flow, no O, no go. And then dietary, D. Nutrition is important, all the micronutrients that go into the physiology of, orchestrating a wound care or a wound healing wound bed. Wound biology is something that I never heard that word in training. I'll hear it all the time on LinkedIn and what I'm reading, and all these wound biologists out there. I mean, you've had some of the greatest wound biologists on your podcast, and learning more about wound biology. I mean, I remember we learned phases of healing in a short, small few weeks on plastic surgery rotation and training, but understanding wound physiology and the dietary, raw materials that are needed to actually enact or engender healthy wound biology. Because what I tell patients is we're doing nothing more than generating a really healthy immune system for your body to heal itself and somewhat wall off this now foreign thing fungating from you that's totally an environment, and that's the E, environmental, the environment for you to live with symbiotically with the environment. And what's in the environment? Microbes. So dietary, and then the E would be environmental. And you really have something very important that may have been subtle in what you said, Cassandre, was the environment of the patient. That is 100% something to be aware of. In your case, his bed needed to be focused and centered in the doorway, facing the door, to convince the patient to lay on a different side, because the side he chose to lay on to preserve his integrity and his safety was the side of the ulcer. I've done that many times. Patients love to stay in their bed because that's their safe space, and they watch gun smoke every day, all day long. Well, if the TV is on the right side of the bed and their ulcer is on their right trochanter, guess what? Not going to work.
Right.
Take and reevaluate the environment. And that's something where allied health professionals, OTs, come in and they can help with that. But being astute to that in our minds as the assessing provider and team leader of the care plan and the protocol, thinking about the environment in which the patient exists is extremely important, because it could be that critical behavior change and positioning change that does everything to change the trajectory of the healing process.
Absolutely.
I think great point, Traci. And I just want to reiterate your emphasis on the importance of patient education, because I feel like, and I've been guilty of this before, that we underestimate how much a patient wants to learn, and they're hungry to learn. But we just need to learn how to optimize good bedside manner and learn how to be good at sharing information on their level, right? Not on their level, but just to their understanding in layman's terms. There you go. But I think we just, with every interaction, ask the patient, do you want to learn more about it? Or just go ahead and explain, like, in basic terms, the physiology, because I really also think that definitely optimizes patient buy-in. They just get more engaged. They feel like there's more ownership, there's more autonomy in their healing process. And it's super important.
Yeah, no doubt. So for anybody listening into this, I think it's pretty clear that an interdisciplinary team that involves the patient at the center of it all really leads to better outcomes. And it's better for the patient, better for wound healing, probably better even for the people working in the system, to be able to have that camaraderie, that cadre of people that you can rely on to help you heal this patient, who sometimes are in a very difficult or challenging situation. So anybody listening who is like, I'm totally bought in, I want to create an interdisciplinary team at my institution, where do you even begin?
Well, I always say start from the beginning with a charter, putting together a vision and mission statement. Think about this as an ecosystem of care, big picture, start at a 30,000 foot view and think about, what the problem is, and then reverse engineer something great. Obviously, I think my biggest challenge in developing an IDT was getting provider buy-in, or say professional buy-in, because everybody all of a sudden, like I said, we were lurched into treating patients virtually, 250 orders of wound care dressings across the state of Colorado, virtually in a COVID scenario. So it was sort of like, how do we build a military theater in 1 week? So, or an operating room, and how do we do it virtually? So it's no big, it's not an easy charter, but I think something we talked about in business school was, how do you convince your early adopters to come on board and get off the island, right? Because as you said, we all work in silos, so we're all on our little island, and this is a constellation of those, and this boat is about to sail. And how do we convince them to get on the boat? Well, you have to have a champion, you have to have a vision, and you have to have a mission. And then that individual has to be able to choose and have choice to participate. And I think if you have a good message and you have incentives, of course, everybody does something for incentives, right? Or rewards, those are important. And actually, that is a STAR model. That is something we studied in business school, but structure, function, people, process, rewards. These are all things to develop a solid, high functioning team. And then you rely on people by recommendation to identify who is on that team. And of course, the better the team, the more likely people will want to be on the boat with said team. And everybody's going to put a paddle, and that's in their hand, and they're going to paddle forward on that mission, on that charter, to do what? Well, to heal and provide wholeness and patience. For my program, obviously the incentive was growing the program, helping create a sustainable fiscal program. And so our incentives were create wholeness, create longevity, reduce spending if we can, keep patients out of ERs, urgent care centers, and hospitals, no more sepsis, no more pain and suffering, no more polypharmacy. That was a big one. So we had very directive clinical objectives, but also business objectives. And so you need all kinds of individuals to create this team together and put this together. As I said, weaving the quilt that's going to wrap the patient.
Yeah.
I like your reverse engineering idea, Traci. That's because it's a very good point as far as starting from a point. What's your vision and working from there? Just it makes total sense. So I guess I have a similar thought process, but coming from a primary care view, I would feel like creating the recommendation I would have for the audience is starting with the patient, right? By getting the core disciplines talking about the same patient, their needs. So whether it be, if you're in a skilled nursing facility, the CNAs, nurses, providers, therapy, dietary, social work, then pick one or two habits you can all commit to based on the needs of the patient. So maybe like a 5-minute micro huddle, maybe like a shared care plan, closing the documentation loop. So from my experience, I think once the team understands the patient story the same way, I feel like you're on your way to building a really good IDT. And the rest is sort of like refinement, like Traci said.
Yeah.
So
Well,
that's
the interconnectedness, you hit that on the head. So technology, I think I said structure, but I really mean in the structure. We use technology now, and this is the fourth industrial revolution, right? So you have, using technology to elevate and escalate and advance and optimize people and process. And
Yeah.
so this whole concept of interdisciplinary requires virtual interconnectedness through infrastructure and technology. And so I think something to take away from what you just said, if you just instill a requirement for every individual of the care plan to sign off on the documentation loop and put their signature on the care plan, that they've acknowledged that they've read it, essentially what they and potentially give them the opportunity to contribute to that. That is something that we did in our residency. We had interdisciplinary teams for breast cancer, for lots of surgical melanoma, surgical oncology, topics, and of course, intensive care surgery we did. Everybody saw that care plan, and they saw it because everybody had access to the care plan via the computer. And so if it was just a policy as a part of the program for the physical therapist, occupational therapist, for the skilled nurse, the CNA, the administrator, and the clinician to have touched it, signed off on it, read it, that is bringing them together in a virtual field. I mean, yes, virtual or huddles, face-to-face huddles really helped because we did meet on Zoom, and technology yet again brought us together for COVID. But just that element, and I mean, people again get into a rut. No, I just sign off on it, but you'll be able to, and then hold them accountable, right? If the care plan says patient will be turned and repositioned every 2 hours, then you have policies in place to hold that individual who signed off on it. Call it a coaching moment,
Yeah.
and then you can hold them accountable. And then they're not saying that there's punitive damages, but there really is.
Right.
I mean, there are punitive damages when a patient isn't turned and repositioned according to what the care plan states, because we're now developing additional, also cultivating, perpetuating cultivating chronic wounds in high risk venues where these things shouldn't exist, right? And policy are in place that they're non-events. So that interconnectedness is so important, and I think technology, which could be another podcast. What is the technology that brings these interdisciplinary team members together? How do we build it? What does it look like? Who pays for it?
That's a good one.
Yeah, I was actually just thinking on that topic of interconnectedness and technology. I mean, that's how you two first met. But anybody listening in who wants to connect with the two of you, what are the ways to reach out to you, to connect with you, to work with you? Cassandre, we'll start with you.
Oh gosh, so you can connect to me via email or phone. Well, let's see, what would be the best way? I didn't really think about this. Sorry. LinkedIn would be the best option. You can DM me, and you can just we can talk about my consultation services. I offer legal services in addition to the survey readiness program that I have. So you can reach me through LinkedIn.
That's awesome. What about you, Traci?
Yeah, same. I'm on LinkedIn. If you just search Traci Kimball or Wound Wizard in the search bar, you should be able to find my profile and email me through LinkedIn. Otherwise, www.thewishclinic.com. Contact us. There's an inquiry form you can fill out, and that'll get forwarded to me. Or you can just reach out at info@thewishclinic.com.
Awesome. Well, this has been an absolutely fascinating conversation in which we sadly have to bring an end for today. Thank you all for spending some time with us today, exploring this gap, exploring this truth. Obviously, to you listeners, we want to hear your thoughts, comments, and reactions to this conversation, so please reach out. If there are any particular episodes or topics you want to hear about or guests you would like to see on the show, also reach out and contact us. Also, be sure, if you're listening to this on a podcast app, subscribe and leave us a 5-star review so others can find this content more easily. And if you like this particular episode, please share it with a friend. Also, don't forget to check out our website at wct-us.com for lots more educational content at Wound Care Today. And finally, be sure to tune in next time as we explore yet another aspect of the challenging and rewarding field of chronic wound care. Ciao.